All right, good evening. Welcome to this part two of the group discussion on intestinal stoma. We looked at the indications for the technique, some of the finer aspects of the technique. And today we are in various kinds, classification and types of stoma. But today we are going to talk about the consequences of stoma. Okay, we start with QOL, the quality of life, which is very important. We also look at the closure of the stoma. When should you do it? How should you do it? What are its consequences? And finally, what are the complications of a stoma? It's no brainer to understand that quality of life suffers a lot if complications occur after you fashion a stoma. And so we need to understand what are the common complications. And while I'm not going to great detail about each one of those, I will touch upon some of the common complications and common remedies for those complications. So in the first part, we look at the quality of life after a stoma. What is your view? How is the quality of life affected? Samir?
Um, According to the studies, majority of the patients, um, because of that, dietary style has changed, and
Your
also,
voice is not clear, Samir.
Yeah, Samir, your voice is not.
It's sort of wavy. Can you get a firmer connection? Please, yeah, Nikita, you go on. Yeah.
So, uh, as per the aspects of quality of life, psychologically they are affected, as well as the day-to-day activities, functional effect.
Mhm.
So,
Correct.
so it's decreased quality of life is seen in them.
Okay.
But as it progresses,
Right.
they improve to a point where it's not comparable to the normalcy, sir, but it's better than the initial days of the stoma.
Is it only psychological that is affected?
No, sir. Functional, psychological, and
When you say functional, what function?
so like day-to-day activities, sir, like
All right.
work and
Mhm. So
social.
if you take the overall picture, would you say the quality of life is moderate to good after some time or poor after some time?
So moderate to good after some time.
All right.
Initially might be pure, but poor.
That's essentially correct. Okay. Majority had a moderate to good QOL, and they found that the better QOL it is if they are older, if the stoma is there for longer, if they're employed, and as you said, the functional day-to-day activity, if they didn't have to change their clothing style or change it regularly, and if their sexual activity, if they are sexually active, if that is not affected. And it was always worse if they become unemployed for whatever reason, or if they lose money because of the stoma, and if they get complications of the stoma. Okay, this is very clear. This is a paper from Delhi, but please note that the patient population is not only Indian. They had some Indian patients as well, but it was a review of the worldwide patient population. They had physical, psychological, and social issues. Particularly, they become introverts. They don't go to parties. They don't mingle with people, and that's the kind of problem that they have. But again, most of them cope well with time. And the two important things that they stress is that to help them cope, you must have preoperative counseling as well as regular post-op help. Okay, that is a very important thing that we have to understand. We already talked about counseling, citing, and things like that. And we also mentioned, if you remember, that it is always good to get a stoma patient to come and talk to them even pre-op and induce, a kind of confidence in these people that they can lead essentially normal lives even after the stoma formation. A little more about psychological aspects. What do you think happens to them?
They get
Psychological
depressed.
phenomenon. Okay.
They go into depression.
What else?
Um,
Anxiety
And also they
anxiety.
start eating less, because of the output, they would restrict their eating habits.
That's true. Okay, so essentially psychologically they go into anxiety, depression, and some may go as far as suicidal tendency. So it is our responsibility to make sure that we particularly recognize depression and suicidal tendency and support them in the process. Okay, the first 6 months they're always poor coping. They again talk about the counseling bit which we mentioned, and what is very essential if they are finding difficulty is to have group therapy. Okay, and this you have every place have ostomates, a group of patients and doctors and stoma therapists who form what's called ostomates group. There's an ostomates India as well. There is a Bangalore branch as well. So you can contact them and arrange for individuals to come and meet these patients, have regular programs every quarterly or whatever, and they can meet, and that just mingling and exchanging their difficulties, mutual encouragement will largely address the psychological aspects of a stoma. Okay, and this is a paper from St. John's, which is quite nice. Number of study subjects was small, but they had scores for all aspects of life. The total score, they had a questionnaire, and the questionnaire addressed physical, psychological, social, and spiritual aspects of one's lives. And they had rated those questions. It's a validated scale. And total was given like this. And if you see people with the stoma, everything is less. So in all aspects of a life, physical, psychological, social, and spiritual, they suffered. It's practically about half or maybe 60% of what the total score is. All right. So, and again, one of the interesting things that they mentioned here, that the Indian study, there was less complaints about sexual difficulties. Maybe our structure in our society where we don't talk about it, it doesn't necessarily mean that there was no difficulties, but they wouldn't talk about it perhaps. So it's important to realize that we have to give them support once you form the stoma. It's not that you do the stoma and leave it at that. You have to address their requirements. So when you talk about stoma care itself, primarily fashioning the stoma is a surgeon's responsibility. Doing it properly, and we discussed it last time. The actual care, even though the surgeon is in overall charge of the whole process, is done by a stoma therapist, a specialized nurse who would do it. So as we said, involve them preoperatively, mentioned about ostomates, and it's not enough if you just talk to the patient per se, himself or herself. It's important to involve 2 or 3 family members or caregivers who are going to be with the patient. Okay, so it's always important to train them up along with the patient. If the patient is very elderly or is disabled or differently abled in any way, you may have to do all the training to the caregivers or the family members. Okay, so if I talk about the principles, I'm not talking about the nitty-gritty day, every day, what you use, what you do, all that. What would be the principles of giving a stoma care? What would mean that the patient can cope with the stoma well? All right, Praveen.
Sir, protecting the stoma, emptying it,
Okay.
and changing the stoma bag
Those are all the
adequately.
nitty-gritties. What are the principles? How do you start by saying these are the things that have to happen with the stoma and the appliance before the patient is comfortable with it? Because as a surgeon, you have to address these aspects. That's why I'm asking this question. None of this is theoretical. Yeah.
Protecting the skin, sir.
All right, very good.
Then
even before that,
application of the stoma.
Okay.
This.
What are the principles? What are the things you focus on?
So like the proper pouch placement, how it will be done that way, sir. And what are the different types of pouch systems which are there?
Yeah. Okay. So the first thing is there should be no leak. the pouch, the base plate and the pouch must sit nicely and snugly around the stoma. Okay, when that happens, there's no leak under the plate. There's minimal exposed skin. So skin problems don't occur. There must be a good fit of the belt. They need to have a belt to hold the pouch in place. There must be a proper assembly between the base plate and the pouch. And you have to give some attention to deodorant and the diet that increases gassy things like potatoes, for example, and also focus on psychological and family support. So the important thing is to have these two: good fit of the belt and these three, in fact, the leak-proof fit and a proper assembly to the base plate and the pouch. That's a very important thing. Okay, you have one piece or two piece kinds. This is usually a temporary stoma. Okay, usually an emergency stoma or something that you use in the first few days after surgery. You have a composite sticky part and a pouch, and the sticky part has concentric rings. Samir, why do you think they have these rings? If you notice closely, there is even some measurements on it. Why do you think they give it? So your voice is still not right, so you're going to get away with it today. I'm not going to ask you any questions. All right? All right.
Samir, try getting off the video only, just audio. I think your bandwidth may not be adequate.
He's not on video. I don't think he's on video. It's just that his connection is not good. Okay. Anyway, Nikita, why do you think you have these concentric rings?
So depending upon the size of the stoma, we can
Correct.
actually make an incision on the
make a
ring
cut. Yeah.
to
So
snugly fit into
basically you measure the diameter of the stoma, and all these are concentric rings which give you the diameter. So you decide how much you have to take off and then stick it. Okay. That's all there is to it. But the more conventional one is the so-called two-piece system, where you have the same, this is the base plate and this is the pouch. There are methods by which you fix the base plate. Of course, it will stick next to the skin and the pouch will get locked on. There are different methods of locks. They get locked on to it. And the whole assembly is then belted like this. The belt goes around the waist and the whole thing is kept in place so that nothing gets slipped off. Okay, this is a basic simple mechanisms of all stomas, and the stuff, the substance of which this base plate is made is either what we call stoma adhesive, which is a proprietary substance, or caraya. Stoma adhesive has a part of caraya as well. It will also have other components like zinc oxide and things like that, which have basically three properties. One of them is that it sticks well. Second, it protects the skin even if there is a leak. And third, it sticks better, and the safety of this mechanism is better when the substance is heated to the body temperature. Okay. If you have certain things, many adhesives, when they are stuck onto the body, they can actually become undone. But these appliances are designed in such a way, formulated in such a way, that they actually stick better when when they come up to the body temperature. So this is a classical stoma therapist's work table with these are the measures. If you can see my pointer, this tells them what the diameter of the stoma is. It's a measure, just like we use a measure for when we use our intestinal staplers and things like that. And to make it stick, you have a caraya or a stoma adhesive glue as well. So there are little, when the base plate doesn't sit very nicely on the skin, if there are certain depressions or little gaps and things like that, they use the same substance as what the base plate is made of. Same substance, caraya or stoma adhesive or some such related thing. These are not the only two, there are others as well. So it's called building up the base. So they put this kind of paste and build up a flat platform on which they can stick the base plate. I think whenever, you will not be probably called to do it, but I learned it myself from a stoma therapist in the UK when I was training. I went with them and learned how they do it. And it's a very, very, artful and skilled job. So once you are managing with the stoma and its appliances, then we need to address the question for all temporary stomas. Of course, if you have an APER, that's a different issue. It's a permanent stoma. But for all other stomas, we'll need to consider closure. So the things we ask ourselves are, when is the best time to do it? How do you do it? And what are the complications of that closure? I'm not talking about complications of stoma itself. We'll come to that after this section. But the issue is, what are the complications of the stoma closure? That's what we need to discuss next. So when do you think we should close the stoma? Sanya?
So generally, if we have done for like a non-infective case where there is no active infection or something, 4 to 6 weeks
Okay.
we consider closure, sir. But if it is an infective case that we have done, for example, Crohn's or IBD, where we have done diversion, then depending on how the response is for the medication or other treatment for that part of the disease, then we decide about closure, sir.
So what are the factors you consider before closing? You mentioned infection one. But
Yes, sir.
in general, what are your concerns as a surgeon before you close your abdomen?
Yes, sir.
Your stoma.
Stoma. First, if we have done an resection anastomosis, sir, and if we and we have done a diversion for that, then we have to make sure that the anastomosis site has healed.
Okay.
There is no any infection or gaping or anything. The anastomosis site has to be healed, sir.
Right.
And
you mentioned the primary disease has to be
yes, sir, taken
quiescent.
care of.
Okay. What
Yes,
else?
sir.
Just
And
mention points.
in general condition of the patient should also be good.
Yes,
sir.
nutrition,
His
very good.
nutrition should be good. Anemia corrected, albumin, everything has to be corrected.
Right.
And then we can go ahead with closure, sir.
So when you say 4 to 6 weeks, why would you do that? Are there any? And you said you shouldn't do it for an infective case.
Yes, sir.
What would be your consideration for that? What are you worried about if you go in early in an infective case?
If we go in early in an infective case, it can the anastomosis of the closure which we do can leak, no, sir.
Why would the closure leak? Because you think there's active infection?
Infection,
Do you
yes,
think
sir.
the active infection will be better at 12 weeks rather than 4 weeks?
No, sir, we have to take care of that infection before we go
All
ahead,
right.
is what I mean.
Okay. And if you leave it, what other things are you worried about? If you leave it very long, or even if you take it going else, what else are you worried about apart from the infection and the breakdown of your stoma?
Dense adhesions that would form will be difficult to release.
Correct.
Yes, sir.
So adhesions are an issue, and you want the adhesions to mature. You don't want it to be friable.
Yes,
You
sir.
don't want the gut, and you don't want, all adhesions go through it happens in any acute inflammatory process. It undergoes, it goes through a process of fibrosis.
Yes, sir.
It's called woody fibrosis, which is very difficult to break down. You leave it a little longer, these things mature, and your
dissection becomes
closure
typical.
dissection will be a little easier if you leave it longer. So
Long,
basically, you're right in what you said. The considerations are that you want to make sure that the underlying disease is clear, the anastomosis is healed, that the adhesions are stable, and there should be no inflammation around the stoma. There should be no complications of the stoma, and the general condition of the patient. You understand that for various reasons, a good 30% of the stoma are not at all reversed, even though at the time of fashioning the stoma, the surgeon has an idea of reversing it. It will not be reversed at all. So that is an important thing that one has to consider. Okay. And so the timing, we already discussed it, so I'm going to go through this, is that ideally everybody mentions a period of 8 to 12 weeks when it's very, very safe. Okay. But there are many papers, I quoted this, the early closure versus conventional closure. Early closure, they defined it as 2 to 4 weeks, and conventional as 8 to 10 weeks. The cost and stoma complications were actually less, and there was a better quality of life because of early closure. But all other parameters like post-op complications, leaks, and other things were the same. So if you have as we mentioned earlier, if you have no active infective process, if it's done for covering an anastomosis, if you have made sure that the anastomosis is healed, then you are within your rights to close it early within 4 weeks, and you don't necessarily have to wait 8 to 12 weeks. Okay, it's left to the surgeon and the patient to decide when to do it. Okay, colostomy closure again is as important as it also applies to ileostomy. It's as important as fashioning it. So it has to be done by a senior or by a junior under a direct supervision of a senior. High wound infection rates and high parastomal hernia rates. So it's important to make sure that you do not damage the bowel when you undo it. Important to make sure that you ensure that vascularity is not compromised, and make sure that, like in any anastomosis, it's no less important than a full anastomosis. Like in any anastomosis, you have a tension-free, well-vascularized, watertight closure. Also make sure that you do not cause a stenosis at that point, because that can be one of the sticky points in the post-op phase. And as we said, the wound infection and parastomal hernias are very common. And so some people say you should do a purse string closure of the facial defect. Okay. And the string and the skin as well, versus a linear closure. Okay. It depends on the size, of course. If it's a very big defect, you cannot do a purse string, but most of them are manageable with a purse string suture. So they say that it's better. There are some papers to that effect. And if you're worried about parastomal hernia, there are some proponents of a use of a prophylactic mesh. Okay, that's talked about a lot. I don't usually do it, but you may think that this is counterintuitive. When you have a high wound infection rate, how can you put a mesh in it? No, that's true, but people have used it, and they have large series, not even small series. Large series have shown that the use of a prophylactic mesh is quite useful. Okay, so that's something that you have to do, but I don't do either of them. When I close my stomas, I do in a conventional way. I don't necessarily do a purse string. I do a linear closure, and I don't routinely use a prophylactic mesh. Okay, what do you think are the complications of a colostomy closure? I'm not talking about colostomies. I'm talking about closure only. Nitya.
So again, that can lead to leak when we
All right.
close the.
So when we talk about this, you must always, as I keep on saying, for you to get a complete comprehensive list and to process the thought, the process in your own mind. Thank you. Start like that. So what are the early complications, late complications? Go on.
Early would be infection, leak.
Yes. Yes. Okay. So you would say there will be an infection. If there's an infection, there can be an ileus. It can be a leak, and of course, generalized sepsis. Bowel obstruction, stenosis. I told you that you should note, particularly in ileostomies, you should make sure that you do not narrow the bowel, and you add a little kink or a little adhesion to a surgically narrowed bowel. You end up with a bowel obstruction, and they can have a parastomal hernia. These are the complications of colostomy closure. Okay, so I'll pause here and invite comments and questions from the students, and comments from Niranjan and Ravi.
Sir, no comments. Just one doubt. Is it called as incisional hernia or parastomal hernia when we close it?
An incisional hernia next to a stoma is called a parastomal hernia.
Allah, when we reverse the stoma,
yeah,
is it still called as parastomal hernia?
No. That is, when you reverse the stoma, it's an incisional hernia.
Allah, because that complications parastomal hernia anta itadake ashte.
No, this is Atara. Okay, fair enough. I take your point. You should call it you're right. You should call it an incisional hernia. You're right. Yeah.
Otherwise, nothing.
Yeah. You're right.
Sir, another thing is, when you talked about putting a mesh parastomally, is prophylactic mesh. Are you talking about while you are creating the stoma, or are you talking about when you close the stoma?
A prophylactic it can apply to both, but generally it's applied to when you're fashioning a stoma.
Yeah,
Okay,
I
and
think
it can you can close when you have a closure. If you feel that the tissues are not very good, you can actually close it instead of a facial suture closure. You can put a mesh and close it. Both
yeah.
are
There are
yeah
papers which have shown prophylactic mesh repair when you're closing the stoma as well.
correct. That's what I'm
There is
saying.
benefit.
Both. You know, even when you're fashioning or when you're closing the stoma, you can use it as a prophylactic mesh.
Sir, I think I think you stressed quite a lot about the consent and support of the patient, but
Yeah.
I think there is a lot of misgivings and lot of fear and fear of the unknown among
Yeah.
the patients. I think it would be for me also, just
Yeah.
like any other patient.
Right.
So I think, but the startling thing is, if you interview people, about 6 months following the stoma, about 75 to 80% of them are happy to keep it.
Right.
Especially people who actually were very fearful and scared of the stoma realized that they were actually afraid. Probably the fear was fear of the unknown and psychological aspects. But once they experience it themselves, and
Yeah.
as you said, with support and things like that,
Yeah.
they are actually happy to keep it. And many of them actually don't want it to be reversed also. Probably
It's
again, it is a function of the severity of the disease they had,
right.
especially if it is inflammatory bowel disease and things like that.
Right.
Maybe they will be happy to
Yeah.
have a stoma where it can be much more controlled management rather
Right.
than
Yeah, the
taking
figure may
the
not be,
other aspect.
yeah, totally agree. Figure may not be as high as 80%. It's more in the region of 30%. And that 30% includes, medical conditions and social conditions and psychological conditions. About a third or a little more than a third, choose not to close the stoma, even though it is possible to close the stoma. That is the point there. But yes, people, as you know, as Nikita mentioned earlier itself, and as we also saw from the literature, they are very apprehensive in the beginning, but when days pass by, they really do very well. They cope with it very well, provided your support is good and you do not have a complication of a stoma. So we
Sir, I
come
have
to,
a doubt.
yeah,
Sir, what is this purse string technique, sir? I didn't understand the closure using a purse string technique.
when you have undone the stoma, when you put it back in,
Yes, sir.
you have a circular defect, right, in the fascia.
Ha.
And or even the skin will be a circular thing. It's not a linear thing like a laparotomy wound.
Yes, sir.
But as you normally see, we usually close it with a regular linear suture, as we do.
Okay.
You understand? We stitch it.
Yeah. So basically this.
As a line.
Okay, sir. So
Instead,
suturing that we talk about is for the skin and the fascia, not
yes,
for the stoma
not
reversal.
at all, not at
Not the
all,
bowel thing.
not
Okay.
the bowel. It's only for the fascia and the skin.
Okay. Got it, sir.
Okay, yeah, that's the point. Yeah. But usually, particularly when you have a loop ileostomy or a loop colostomy, as for a diverting stoma, you don't do an end stoma. That defect is a little big. And that's why I do a linear closure. But I want you to understand that there are papers and there are people who do a circular, uh, stitch for that. Yeah. So we
Okay.
come to the complications of a stoma. Yeah.
Sir,
Ravi.
one more point.
Yeah.
The last point about Hartmann's procedure. I
Right.
think when students, whenever you do a Hartmann's procedure, generally the reversal of Hartmann's is a much more major procedure compared to the original Hartmann's, and do not take it lightly, because I think I think many of them end up with a lot of problems.
Yeah.
So
Yeah.
the reversal of Hartmann should be taken extremely seriously.
Absolutely. Yeah.
As much as or even more than the original operation.
Yeah. Point well taken. Yeah. Okay. So let's move on to the complications of a stoma. All right, Praveen, go on. List them.
It can be divided into early and late, sir.
Right.
Early, it can be within 30 days.
Right.
Stoma necrosis, stoma ischemia.
Yeah.
Ischemia followed by necrosis. Stoma retraction.
Right.
Mucocutaneous suppression.
Okay.
Late might be parastomal hernias.
Right.
Retraction.
Right.
And
Go on. Okay, so we added one or two more, okay, early and late. It doesn't matter if you don't have intermediate, but we added an important part called the intra-op. What could be a complication of a stoma? You can't obviously call it a complication. It's a rather loose application of that term. But any difficulty, what would you have? What would be an intra-op difficulty?
Mobilization of
Inadequate length.
That's it.
adequate length.
Inadequate reach and ischemia. These are the two things which you will straight away face, if the patient is obese, short mesentery, or an acute infective process in the abdomen, like a fecal peritonitis or a long-standing peritonitis, 3-4 days old, or a dilated bowel. When you have all that, very difficult to mobilize it onto the surface of the stomach. And ischemia is very common, kinking, pressure on the mesentery, or arterial insufficiency. These are the intra-op complications. And I think to some extent, we addressed these issues when we were talking about the fashioning of the stoma. The early complications, skin excoriation, which is very, very important. Mucocutaneous separation that you mentioned. I don't know if you mentioned skin excoriation. Did you, Praveen? I don't think you didn't. That's the first thing you must mention. Please understand. You can have a peristomal abscess, high output, not directly related to the fashioning, but it's a part of an ileostomy. Again, like we talked about the closure, you can have an obstruction and an ileus, and you can have hemorrhage and hematoma, which in turn can lead to some kind of a vascular phenomenon or ischemia of the bowel itself. So these are the early complications. And so we next have to go on to intermediate complications, which are essentially retraction and stenosis. It doesn't happen on day one. You can have a fistula from the side of the bowel onto the surface of the skin adjacent to the stoma, and you can have food impaction. It's like rectal impaction. It can also happen in a stoma, particularly if there are kinks at the point where it enters the peritoneum or the abdominal wall. That's why we keep saying that you put your finger in after you've fashioned it to make sure that there are no kinks as the bowel enters the abdominal wall. And the late complications, of course, parastomal hernia, granuloma, prolapse, or recurrent disease. Just like you have a disease at the anastomotic recurrence we talk of in cancer colon, any disease, be it inflammatory bowel disease, be it a neoplasm, can recur at the site of the stoma itself. Or you can have new neoplasms at the stoma as well. You can get a squamous cell carcinoma. That's not called recurrent disease, but you can have a squamous cell carcinoma at the junction of the mucosa and the skin, for example, of a permanent ileostomy or a colostomy. So these are the complications of stoma. As you can see, it's a very long list. I'm going to go back just to recap for all of you. Okay, skin excoriation, very important. Separation, abscess, high output, ileus, hemorrhage. You can have retraction or stenosis, fistulation or food impaction, and you can have parastomal hernia, granuloma, prolapse, and recurrent disease. All these are possible in stoma. We'll address some of them before we close this. Skin excoriation is very important. Much more common in ileostomy than a colostomy. There are various gradations for it. The so-called Sachs classification is one of the commonly used things. It's very important to have it. It's listed here, as you can see, L1, hyperemia, erosion, ulceration, with full thickness skin loss, and proliferative lesion. Okay, abnormal. This is the granuloma that we talked about. Hyperplasia, granuloma, or even a neoplasm. So this is L, and the T1, 2, 3, 4 refer to the 4 quadrants. TV means all quadrants. That's T5. It's not TV. It's all quadrants. So 1, 2, 3, 5. So you can this way when you say T1, L2, it means that you have an erosive lesion in the upper and left quadrant of the stoma. This way you can nicely describe what is there, and we can follow it up after treatment to see how good the improvement is. So if something that was occupying all 4 segments occupies only one, it's less, and an ulcerative lesion becomes just a hyperemic lesion, then that's better. It's like that. You can objectively score the skin change. The incidence is really quite high, 20 to 40% in an ileostomy. It's about half of that in a colostomy. The risk factors are obesity and emergency surgery. We mentioned about the fit and the gaps. If you leave gaps, then the leaks are higher, and so you fill them up with the caraya and make a form and form a flat surface to protect the skin properly. And if certain, these are all commercial appliances, and certain manufacturers don't give you the kind of appliance you need to get a nice tight fit, you can always go for another company and try to get a better one. And very, very rarely, in fact, I have not had to do this at all, just for skin excoriation. You may have to reform the stoma. More often in ileostomy, as you said, if the pouting that we require, 2 to 2.5 centimeters or 3 centimeters of pouting for the hernia in a dependent part, if you can't get it the first time, and if you have skin problems, you may have to reform it. Okay, and I'm going to run through certain complications. They're all my own cases, which I've had over a period of time. This is a retraction. As you can see, nice flowery thing has gone away. Stenosis also looks like this, but as I remember, this particular thing was not stenotic, but just retracted. You can have granulomas around it. It's always important to biopsy to make sure that it is inflammatory and not neoplastic. One of the reasons for this could be a little remnant of a stitch left underneath. Use absorbable sutures, but if something doesn't get absorbed, or if there's a bit left there, then you may have to take that out also. All right. It can also happen as a progranulation tissue when the mucocutaneous gap heals. So it's important that when you fashion the stoma, you do not leave a mucocutaneous gap. This is a prolapse, quite a dramatic one. You will have to reoperate to get it right and make sure that you fix the bowel properly so that it doesn't come out very dramatically, like you see in this case. In this case, it only came out, but there is no vascular compromise. Sometimes you might end up with a vascular compromise as well, in which case you must do it as an emergency. Colostomy necrosis is a terrible problem. You would have seen that everything is okay, but something happens, perhaps a kink or an inflammatory edema or even a small embolus or thrombosis of the mesenteric vessel. You end up with a dead stoma and dead bowel like this. So you really have to go back in and quickly fashion it correctly. This particular patient, I remember very well, didn't come for follow-up. The patient was very ill when the patient did come. When we operated as soon as she came, and fortunately the patient survived. I remember this very well. Parastomal hernias, as I said, are not uncommon, and you'll find a big bulge like this. On top of it, you have a stoma sitting there. And as I said, what you do, and this is the stoma, you can see the bulge and the stoma up there. The glare of the light doesn't let you see the stoma, but the stoma is down up there. And what you do there is, the complications. This, what I showed you, was an uncomplicated parastomal hernia, but you can end up with constipation, obstruction, strangulation, back pain, and cosmesis. These are the problems that are associated with the parastomal hernia, where you need to repair it. And the way you repair it is usually, I do it usually open surgery, but laparoscopic repair has also been described. You can either do an anatomical repair or a mesh repair. The mesh can be onlay, inlay, sublay, like any other incisional hernia, but there's a reduced rate of recurrence with mesh repair. And I always do a sublay, open, mesh repair. That's my usual answer for this, and this is exactly what we do. We mobilize the stoma that is here. See the fascia. We have done a sublay on it, and perhaps because I found this rather tight, I have decided not to bring it up there, but it is at a subfacial plane. That is the important thing. It's not an onlay. And then you clear the whole thing and get the freshen the edges of the mobilized stoma and stitch it in the right place. So you end up with a final result like this. As I said, it's important that when you mobilize it, you would have a bit of a skin there. You can't use that skin to suture. Okay, you won't get a good mucocutaneous join like that. You have to freshen this like you freshen when you're doing a closure of the stoma, and then refashion the stoma as I have shown. Ravi, Niranjan, any comments, and students to ask questions if any?
Nothing, sir.
Sir, I have a doubt, sir.
Yeah.
In the first picture which has been shown,
Hmm.
sir, you said that it is a retraction, but you couldn't differentiate from the stenosis.
No,
clinically.
No, clinically we could differentiate. I mean, it looks like that. That's what I'm saying. When you see the picture, it looks like a stenosis. It sort of looks shrunken. Whereas if you can easily put a finger in, it's not a stenosis. That's the point I was making.
Okay, sir. Okay.
Yeah. Once you put a finger in and there is no stenosis, you'll know it. A stenosis is very easy to detect. You know, it won't take a finger. It's as simple as that. Yeah. A good stoma should easily take a thumb through.
Yeah.
Whereas if you have stenosis, it won't even take your little finger. That's the way it is. Yeah. Okay. Anything else?
Sir, I want to ask the rate at which the mesh infection happens in case of a peristomal hernia. Is it less or is it more common, sir? Because it's very close in proximity to the wound, and also the wound has a stoma there.
Yeah, the infection rate is very low. Okay,
it's low, sir.
It's very low. And that is the kind of counterintuitive things that I mentioned about earlier. Okay.
Okay.
I think what happens then there is, of course, you cover them with 5 days of antibiotics, give them a nice washout when you do it. And this is the kind of, what shall I say, dichotomy or the surprising thing. The infection rate of a mesh repair of a peristomal hernia is not high at all. Okay, I can't, different series quote different infection rates, but it may be at the most 2 to 5%, not more than that.
Okay.
Yeah. Okay, Ravi, comments?
Yeah, I think especially in inflammatory bowel disease, when patients have been given stoma, pyoderma gangrenosum around the stoma is a common problem.
Yes.
And that is one of the reasons why you may have to replace the stoma. Because you said, I think it is quite rare to replace a stoma, but that is maybe one of the reasons, because pyoderma gangrenosum is very difficult to treat, though you can use tacrolimus and all that things. Probably the treatment is better, but still that can happen. Other thing is, I have seen it happen twice. Whenever you are doing a loop, make sure that you identify the proximal loop, which has to be the main thing, because the people have closed off the proximal loop and brought out the distal loop as stoma. Obviously, it won't work.
An end colostomy. Yeah. Famously, Gallagher was, you know, the colorectal surgeon who wrote a huge monumental Gallagher.
Professor Gallagher of Leeds.
Yeah, he had done that. I believe, because his student was my boss. So, so that was great. But right, you may bring out that's while fashioning an end colostomy, for example, you may bring out the wrong end as the end. And so the patient ends up with a intestinal obstruction. You have to re-explore, reoperate and get it right. Yeah,
I have actually operated on 2 of my consultants' similar closure.
Okay,
so unfortunately, it can happen.
It can happen. All right. Okay. So,
sir, I have one more question, sir.
Sure.
I read about a continent ileostomy, like continent stoma.
All right.
I didn't
Yeah.
understand that there is a reservoir pouch that is created, and I
Yes.
tried reading. I could not figure out
It's
how
given
to.
up. That is why sir has
It's
not
given up.
mentioned
That's why I have not mentioned it. It's called Cox
Cox
continent
continent.
ileostomy. What happens is that you have uh, a reservoir and you fashion a valve in the tip. Okay, you
Okay.
do a J or a W or an S pouch for a continent for a reservoir, and then when you bring it out of the abdominal wall, you fashion a valve-like thing where it's a one-way valve. It doesn't
Okay.
allow the contents of that reservoir to come out, but you can put a tube into it at your choice
Okay.
and then drain it out. It's like a valve there, one-way valve, where it allows a tube to go from the outside to the inside of the reservoir to
Uh-huh.
drain the contents, but doesn't allow the contents of the reservoir to come out by itself. But
Okay.
it ended up with a lot of problems like ischemia, stenosis, leak from the reservoir, and things like that. So it's practically given up.
Okay, sir.
That's why I didn't talk about it. Yeah. Okay. So that brings us to this end of the discussion. Questions, comments from the students first, the registrars, and then Niranjan and Ravi to give closing comments, please. Oh, Kritika is here. Oh, young lady who is just passed out of BMC. Good evening, Kritika.
Good evening, sir.
We'll start with your comments then. She's sort of talking to us. She's a BMC MS graduate.
Yes, sir.
Go on, Kritika. Your comments. We are a very open group, and so you can give me a critique. What is a critique, Kritika?
Sir, I think it was a consolidation of everything
No,
I've
what is
done
a critique?
great.
Generally, give me what do you mean by critique?
Yes, sir. It was a very holistic and a complete
No,
class.
definition of a critique. What do you forget about this class? Forget about this. Generally, what is a critique?
My opinion on this.
Yes, it has both good and not so good points.
Yes,
all right.
sir.
So
Yes,
you got to be free enough to say that. Okay.
Yes.
Yeah. Go on.
Yes, sir. So the positive thing was everything that we vaguely did without any rationale, just because our seniors did, was probably consolidated in a proper format.
Mm-hmm.
And learned a lot about it. I missed a bit of it in between, so I'm not sure what else I could.
All right. So you joined a bit late, did you? Okay. All right.
Yes, sir.
Okay. Any other comments or any questions from the others, please? Okay. No comments. Niranjan, close. No, go on. Nikita, go on.
Nothing in specific, sir. It was a good class.
Yeah.
Sir, most importantly, are there any specific important points? How could we prevent the complications while doing the procedure, sir, other than the minimizing the risk factors?
Minimize risk factors. We discussed it in detail in the last class, Nikita. There's nothing more to add to that, about the technique, we were discussing.
Yes, sir. Yes, sir.
Nothing more to add to that. That's all you can do.
Okay.
Yeah. Okay, Niranjan.
Sir, it was very good, sir. No other comments.
All right. Ravi, closing comments. Yeah.
It was both comprehensive yet very concise kind of lecture on first formation indications and now the complications and also closure of stoma. I think important thing all of us have to understand is stoma should be taken extremely seriously. It is not desirable for the patient to have it, but if it becomes inevitable, you have to make sure you've taken due diligence in doing it absolutely properly and not leave it to just the junior because you're tired. And again, the timing of the closure, all these things have to be taken very seriously. Stomas are as such, they affect the quality of life. You should not make it even worse by doing a bad stoma or taking wrong decisions while doing it. I think all these points were brought out very well. Thank you, sir.
All right. Thank you, folks. Good night. And I'll close the meeting now.
Good night, sir.
Thank you, sir.